But I think our data tell us that if you're willing to invest and if your healthcare service can give you the expertise and the required tools, you can see improvements with or without fancy devices even many years after stroke. And I think that's quite encouraging.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 137 of the Strokecast. Today's episode is brought to you by the fine folks at Modus Nova. To find out if Modus Nova can help you recover use of an affected limb, visit strokecast.com/Modus Nova. And by the fine folks at Like-Minded. To learn if this membership program for brain injury survivors is right for you, visit strokecast.com/Like-Minded. The vagus nerves are two of the big ones. They run from the brain to the gut, and they carry huge volumes of data and instructions to sort of keep our intestines digesting, our hearts beating, our lungs breathing, and more. So, is there a way we can leverage this network to reduce stroke impairments years after stroke? Dr. Jesse Dawson and his colleagues at the University of Glasgow certainly think so, and the early studies do seem to agree with them. Dr. Dawson recently published a paper showing that vagus nerve stimulation combined with physical or occupational therapy can help a stroke survivor recover arm use years down the road. He joins us this week to talk about that research. So now, let's meet Dr. Jesse Dawson. Jesse, thank you so much for joining us on Strokecast this week.
It's a pleasure. Thank you for having me.
I came across some of your work with the new study that came out talking about the vagus nerve stimulation in chronic stroke. Now, I know we hear a lot about things making improvements in more of the acute context, but your work is looking at folks who have been quite a bit longer past their stroke, which it's great to see different things being able to support that kind of recovery. But to start off with, what is the vagus nerve?
Sure. So the vagus nerve is obviously a nerve that we all have, and in fact in the body is really one of the most important nerves for controlling what we call the autonomic nervous system. So there's one on the right-hand side and there's one on the left-hand side. And it has a number of roles which include, for example, control of heart rate, control of swallowing mechanisms, for example, are perhaps some of the things that it's most widely known for, and perhaps controlling digestive function as well. However, that's kind of dealing with the nerve and its, if you like, its role in kind of sending instructions from the brain down to parts of the body. What we're actually interested in is using the nerve as a means for us to communicate from the periphery of the nervous system to the brain itself. So using what we call its afferent connections, which run from the peripheral parts of the body back up to the brain.
That's really interesting because a lot of those functions you're talking about are, those things we don't think about doing. And here in this course of treatment, you're talking about using it to stimulate those voluntary activities then in how people can use their arm.
Yeah. So what we're doing is we're really just using we're almost, if you like, hijacking the vagus nerve. The actual nerve itself, or in this context, it's only useful because it connects with parts of the brain that we know are involved in helping the brain respond to stimulus and to recovery. So it doesn't, if you like, have a direct effect on the arm itself or the brain's ability to make the arm move. What we're doing is we're using the nerve to make the brain temporarily more responsive to the effects of specific high-intensity upper limb rehabilitation. So really what we're doing, if you like, is we're making the brain more adaptable to the effects of physiotherapy rather than, if you like, having a direct effect on the arm. We're really working the vagus nerve, and the vagus nerve stimulator is working almost as an intermediary to make the effects of physiotherapy greater.
Sort of kick the rest of the brain into making it more receptive to the neuroplasticity of recovery?
Exactly, yeah.
It's amazing how flexible the brains can be when we apply just the right thing to them.
I think that's right. I mean, I think we've recognized for a long time, and even if we deal at the level of anecdotes, I think we all know of some people who've had miraculous recoveries, and then we also know some people who unfortunately have had very little recovery, and then most people sit somewhere in between. And really what we're trying to do is make a higher proportion of people's brains become those that respond to rehabilitation therapy.
So when we're talking about this vagus nerve stimulation, this is not something that is just a technology sort of developed for stroke treatment and experimentation. This is used for other conditions as well. What are some of the other things reasons why we stimulate the vagus nerve?
Yeah, so the main treatment for which the main condition for which vagus nerve stimulation has been shown to be beneficial is in people with treatment-resistant epilepsy, so people who suffer ongoing seizures despite being on adequate medication. And I think that tells us a number of things. It tells us obviously that stimulating the vagus nerve does have an effect on the central nervous system. The stimulation approach used in conditions like epilepsy, where it just rolls on and off in what we would call an unpaired basis, is very different to what we're doing, where people get very short bursts of vagus nerve stimulation at very specific times during a therapy session, and only then. So that there is a difference, although the mechanics, if you like, of the nerve stimulator is very similar. It's really the frequency and the timing of the stimulation that differs.
In some respects, when we're talking about the timing and the stimulation, I think even at the most basic level, obviously it's very different, but many stroke survivors have worked with TENS devices for e-stim to just sort of trigger the muscles in the wrist or wherever. But, we're probably familiar with adjusting the settings on that device for wavelength and time to get different results.
Yeah, that's right. In our case, so far, we've really just used one stimulation setting, which appears to be effective. So I think that's an important kind of difference for stroke survivors, and is that there's actually very little that the person needs to do, with regard to the stimulation. It sort of happens in the background, either activated by a therapist during a therapy session, or activated by a magnet if somebody's doing home exercises. So there isn't, it's an interesting thing in that once the device is inserted, the person would almost not even know they had it, and they may not even feel the stimulation during a session. For example, there's no setup time at the start of a physical therapy session like there are with other forms of peripheral nerve stimulation.
Which is good, because when we've implanted something like that close to the nerves, we really don't want to be messing around with it that much after the fact.
Yeah, absolutely. We want it to be, simple and implementable. I think that's right, and something that people can keep using at the required intensity, and it's easy for people to use. And I think in this case that certainly is true.
Given that, how did you decide to try this for stroke? Why would we want to try that to see if we can activate the motor cortex to control an upper limb?
It was established, some time ago that vagus nerve stimulation paired with some form of input, and the early studies actually used auditory tones, could cause neuroplasticity, so could make the brain adapt specifically to the stimulus. Now, although tinnitus actually is an area where some work has been done and is an important condition, I think from a sort of commercial perspective and from a maximizing the impact of a treatment perspective, obviously stroke is the one that would immediately come to people's minds, because it is so prevalent and so disabling for many people. And in particular, arm weakness tends to be something that doesn't respond, say, quite as well as lower limb weakness does. So I think really it was, once the concept of vagus nerve stimulation paired with inputs was established that it could improve neuroplasticity, really stroke is the obvious condition for people to suffer because of the amount of suffering and the frequency.
So the sheer volume and the association of stroke with neuroplasticity, or stroke recovery with neuroplasticity, then just seems like a natural fit for something else that you've discovered can engage that neuroplasticity.
Yeah, absolutely. And I think within, a population of stroke survivors, we certainly recognize that improving arm function is one of the most important thing for them, and also is one of the most difficult things to treat. So it was a logical, first step for human studies on many levels, I think.
That makes a lot of sense. As here I am having just taken off my hand splint overnight for about 20 minutes ago. So we've mentioned that these are implants that are involved. Can you talk a little bit about just the nature of the implant and the process for doing that?
Yeah, so it is a fully implantable system. So by that we mean, there is no external parts of the device. It's fully implanted underneath the skin in the way that, say, a cardiac pacemaker would be. And that's probably the most accessible kind of parallel to draw. The stimulator, the device actually sits in the same place as a cardiac pacemaker would, just below the collarbone on the left-hand side, and so in the upper chest on the left-hand side. But rather than the leads being tunneled beneath the skin to the heart, they're tunneled beneath the skin to the vagus nerve on the left-hand side of the neck. So just adjacent to where you would feel the pulse on the left-hand side of the neck is where the vagus nerve is that we access, and that's where the lead attaches to. The procedure itself is relatively straightforward, and I don't mean that from a sort of technical perspective. Obviously, it requires a skilled neurosurgeon or ENT surgeon to do it, but from the patient perspective, it would typically be a day-case procedure with low risk of complications and with mild post-operative pain, for example, in a few days afterwards. We do all of our procedures, and all of the procedures in the study were done under a general anesthetic. And I think that's, a very important point for people to understand, that while in day-to-day medical practice, the risks of general anesthesia are extremely low, that is with a selection process whereby an anaesthetist and a surgical team, they're not going to do a general anesthetic on somebody in whom they think it's unsafe. And I think that is an important point for us to raise, because we do get approached by a very large number of people saying, well, my very elderly, very frail, mother is in a nursing home who, has a number of comorbidities. Would they be eligible? And the answer, sadly, is going to be no, because although general anesthesia is safe, it obviously does come with some risks, and in very frail people, those risks would not be something worth taking. But clearly, a great many people with stroke are relatively fit and well otherwise, and would be very good surgical candidates. So the risks of the procedure, provided that has been thought about and has been, there's been a decision-making process with an anaesthetist and with a surgeon, I don't think are barriers to the therapy, or something that patients should be too concerned about if they were eligible for the procedure in the future.
Yeah, and the procedure itself, since we're taking the space that would often be used for a cardiac pacemaker, if somebody, obviously folks don't have the cardiac pacemaker, but the core of the procedure is one that is well known and well done by thousands of surgeons around the world. So we're not treading a ton of new ground there. We can build on the experience we have in the medical industry to be able to do this in a safe way.
Absolutely, yeah, that's correct. It's a standard procedure during, for example, training of a neurosurgical, resident. It would be standard for them to learn these techniques, and it would be a standard procedure for most neurosurgeons to do it.
So this study, it was a blind study, meaning that patients didn't know if they were getting actual treatment or if they were getting a sham treatment, or basically an inactive vagus nerve stimulator. So, I mean, after the study, were these devices removed, and how do patients respond to the idea that, well, we're gonna perform surgery on you and put a thing in there, and we don't know if this one is going to actually work or if this one is turned off?
So there's sort of two aspects there. The first is, during the study, we obviously had to try and weigh up the real concerns that if we didn't do things properly, we could have what we would call a false positive result. So, if we only implanted one group of people and not the other, there could be other explanations if the device group did better. It could be that they were more motivated because they believed in the device rather than the device itself, for example. So I think there were real concerns that if we didn't do this properly, we could get, a false untruth, for an answer. So then we have to think, okay, well, what's the alternative? The alternative is to fully blind the study. But then, as you point out, you have the situation where you put people at risk and you switch off the device in half of them so they have no chance of benefit from the procedure. Now, you could argue that if people are fully informed and they wish to do that for altruistic reasons, then it's possibly acceptable. But really, the way that we chose to overcome those issues was that at the end of what we called the blinded phase of the study, so once we'd completed the follow-up, we would look to see which patient was in which group, and those that didn't get active nerve stimulation were offered the similar treatment. So they were offered a repeat course of the intensive physiotherapy with the vagus nerve stimulator. So what that meant was that we were able to run a blinded study, which gives us some certainty that the treatment effect was real. And we also gave every patient who signed up the opportunity to receive the active intervention. Now, of course, at the point people signed up for the study, they didn't know whether this would work or not. So there's always that element of risk in a clinical trial, but at least it's something we can't avoid, I guess. So everybody had the chance to receive the active treatment. So typically, at the end of the 90-day study, those that were control patients didn't want their device removed because they wanted to receive the course of active treatment. And in fact, everybody bar a handful of participants in the study were keen to proceed to the long-term follow-up phase, which lasts for at least 2 years, where they continue doing the home exercises with the support of a physiotherapist and keep receiving vagus nerve stimulation at home. So every participant was offered the chance to have the device out, had a consultation, but the vast majority of people wanted to keep trying to improve and keep the stimulator. But of course, a few people had it removed. And in our previous studies, a few people got to a level whereby it was almost pointless to have the device in because they'd made such improvements that we suggested to them they should consider it being removed, and that was done.
That then becomes a really interesting approach. So we get to find out if it's actually doing the job in the first phase without having to worry about things like placebo effects and things like that. And we get a longer term study out of it where it, granted the longer term, it's no longer a blind study. Everybody knows they're actually getting treatment, but you do get to look at some more long-term impacts and see if these results persist and even grow over time.
Correct, absolutely, and of course it's it's a shame, if you like, that those long-term data will be limited by the lack of blinding. But I think if we see a difference at the end of a high-quality blinded study, and we see that those participants don't regress over time or perhaps improve further, which would be really quite out of keeping of what we know happens. People tend to can respond to quite intensive treatment, and then as time goes on and life, gets in the way, and just think about your motivation to keep doing an hour or 30 minutes, an hour of therapy every single day. It will wane over time, and often we see people regress a little. So I think that's right. Even if we don't have blinding, if we see that the effects of the vagus nerve stimulation are long-term and sustained over a period of many years, that would be hugely, hugely encouraging.
At the very least, it would certainly make it easier to justify doing an even larger study to look at long-term applications going forward, going beyond the 100 or so in this study and doing studies that can be upwards of multiple hundreds or thousands of people.
Yeah, absolutely. And I think that's right. I think one of the, the outstanding questions, is very much what next and how can this be refined? And I think we, in many ways, need to find that balance that if this does become an approved therapy, that even with the data that's already available, how do we keep progressing it to make sure that we're even better at selecting the right people, those who will respond, and select out those people who will respond most, and refine the treatment if people aren't responding well to make them respond. So there's lots of unanswered questions. And while the data so far are very, very encouraging, I think, further study even after regulatory approval will be really, really important.
This initial study has shown some very promising results, some really good results. So let's talk a little bit then about the results we've seen so far.
What we found in the study was that those who received vagus nerve stimulation had a bigger change in our main measure of arm movement, so upper limb movement or impairment, called the Fugl-Meyer score. It's quite a complicated measure to take, but it really looks at the synergy and the quality of movement in the upper limb. So the people treated with vagus nerve stimulation had a bigger improvement on that score. So that tells us that it did improve the quality of arm movement, if you like. Now, the between group difference in that score was quite small. It improved by between, depending on what time point you measured it, 5 and 6 points in the vagus nerve stimulation group and around 2.5 to 3 points in the control group. So that between group difference is quite small. But what's important was when we looked at what do those differences mean, because even if you're an expert in the scale, what does a 6-point improvement in the VNS group and a 2.5-point improvement in the control group actually mean? What does it mean to a person? There's quite a lot of data showing that if you, in a chronic setting, so in somebody who's had a stroke for many years, an improvement of 6 points is associated with what the patient themselves would define as an excellent outcome. So an important improvement, a clinically meaningful improvement, so a change in an activity of daily living, increased abilities to do things that matter to that person. So when we looked at that, we found that the number of people in the control group who had that good outcome was just under 25%, and the number of people in the VNS group who had that outcome was approximately 50%. So the rate doubled, and almost half of people treated with VNS had a clinically meaningful improvement in the Fugl-Meyer score. So what we take from that is that although the between group difference was small, we appear to have moved the distribution, if you like, of the Fugl-Meyer score, the measure that we use, sufficiently far to the right-hand side that a really important number of people had a clinically important response. Now, it is important, I think, to put even that in context. I mean, yes, I think work that others have done with stroke survivors tells us that this is an important improvement, and it was supported by some of our other measures that we use and some of our quality of life data. But it's not necessarily a miracle in that, we're not suggesting at all that somebody who has almost no arm movement is, after a 6-week course of in-clinic therapy and 90 days at home, going to have a completely normal arm with no stroke symptoms. That's very much, that's not what we're saying. But we are saying that there is a greater number of people who have an improvement that will be demonstrable and important to them.
So we're not going to go from a permanent tone-inspired fist to typing 120 words a minute in 3 months. Correct.
And I think the other important point there that you raised, which we haven't spoken about, is who was eligible. And although, the average time from stroke was 3 years, which again, I think is really encouraging that we're able to improve people at that time period, there is a context to that. And the example you gave of people with very severe spasticity, well, unfortunately, we excluded them from the initial study because, we wanted to take a group of people in whom we were confident we could deliver the really high intensity therapy to. So we selected people who didn't have severe spasticity, who had at least some, and it could be very small, but at least some thumb and wrist movement so that they could engage in highly intensive physical therapy. So I think, again, it is that group of people who we targeted, and all we can say at the moment is that it appears to work in that group of people. We can't extrapolate out to the more severely affected people, although clearly that's very much what we would like to do next.
So we're talking about this, the people who are eligible then. The study pool had participants in a pretty wide age range from young survivors at 22 to upwards of 80. So how did the survivors' age impact the results they got out of this? And I realized that, when we start slicing it that much, it starts to get harder to determine statistical significance. But
yeah, absolutely. So that exercise of looking at subgroups is not yet completed. We will be looking at those data, shortly, and would hope to publish them. What we can say at the moment is that when we look at response by age, for example, response by stroke subtype, there doesn't appear to be any obvious difference or signal. But you're quite right that when we get to the numbers of responders, and then we look at that by age groups, we can be down to single figures of responders in each age group. So our ability to answer these questions around subgroups and who responds best is limited, even with the data set that we currently have. But certainly we can say at the moment it doesn't appear to be a huge factor. It is important to say that although the upper limit was 80, the average age of participants was a good bit less than that. So we have targeted, we've ended up, if you like, I don't think we've specifically targeted the slightly younger people, but we've ended up with, a slightly younger population than the upper limit of 80.
Yeah, so definitely some more stuff that can be looked at there. Is it pretty much the same way with the sex disparities right now as well? Because we're seeing it was 65% of the participants were men versus 35% were women. Or is that group numbers just a little bit larger to make it easier to see if there were any differences or no differences?
So again, the message appears to be similar, although I would stress that we haven't looked at any statistical analysis yet. We've obviously just, if you like, looked at the raw data, eyeballed the raw data, but it does appear to be the same.
The other thing that comes to mind when we start looking at just the nature of this is obviously the reason a stroke is so destructive is that it is killing millions, tens of millions, hundreds of millions of brain cells, whether by starving them or through an ischemic stroke, or whether by starving them and then crushing them with clots and excess fluid in a hemorrhagic stroke, and just other ways that cells are able to are damaged in this traumatic event. Mm-hmm. So, I mean, does it matter for this process how close the damage area is to the vagus nerve in the brain, or how the stroke itself may directly impact where the vagus nerve connects up in the brain?
That's an interesting question, and where I think it would be particularly important, again, is that in the connection between the vagus nerve and the parts of the brain we're interested in is one of the structures in the brainstem, and we haven't actually studied anybody who had brainstem or what infratentorial, as we might also call them, strokes, so strokes at the back of the brain. We've only studied people with anterior circulation or cortical strokes. Within that, it doesn't appear to, again, make a huge difference whether there's damage limited to the cortex or whether there's more deep white matter damage from subcortical strokes. But again, our ability to, whether or not brainstem involvement would make the treatment less likely to work because there would be an absence, if you like, of connections with these brainstem structures that are of interest to us, we don't know. And again, that's definitely a question for further study. It doesn't appear in experimental models, it doesn't appear to matter whether the stroke is ischemic or hemorrhagic. But again, we haven't yet done studies in people with hemorrhagic stroke. But again, we very much hope to in the future.
That's one of the points of a lot of the stroke research and research in general, is that a research study is intended to answer a very specific question and to try and provide data about that very specific question and not the entire world. And that's why a lot of these things we just don't know yet.
Yeah, absolutely. And I think, when these studies are, extremely difficult to do and, very costly. And we've learned, I think, bitterly in many decades of stroke research that unless we are clever in how we target people, we're unlikely to see benefit, even if benefit exists. The notion of stroke being one thing, one condition, even just ischemic stroke, we no longer think that's the case. And I think that's why we are now starting to see things work, our understanding that one stroke is not the same as the other, and that there are different mechanisms of stroke and there are different types of recovery, for example, is hugely important. So I think we very much needed to be quite specific in who we studied, because, like all interventions, new interventions, you almost only get one chance. If you don't show something, nobody's interested in funding the next steps. Whereas now I think we have the position where we've shown that something works in one group of people, and we can now say to all the people with the money, can we now please do a study in hemorrhagic stroke? Can we now study people with really severe arm weakness, and try to move things even further forward? So we are limited in what we can conclude in terms of the types of patients we studied, but, I think it was definitely the right thing to do, to overall move forward.
Absolutely. That's sort of one of those core things about recovery too. You don't have to get there overnight. You just have to try and be just a little bit better every day. Just try and get a little bit further every day. With these results and what we know now, is there anything you can take from this study that individual survivors today can use to drive our recovery, or can take some solace in looking at future recovery options?
Obviously we're very pleased that the vagus nerve stimulation appears to give us an option, subject to regulatory approval and all of these things. But I think, forget about vagus nerve stimulation for a second. I think the two important things are that we've shown in a study that 3 years after stroke, with selection and with careful consideration, a large number of people can improve. And I think that's really, really, really important. That tells us that this notion that, you get to 6 months and then that's you stuck, tough luck, is no longer true or acceptable. And secondly, even if you look at the controls, although the average response in controls was very small in terms of the size of improvement in this Fugl-Meyer score, there clearly is a bell curve, and a distribution to all of these things. And even with just an intensive 6-week course of upper limb treatment and home exercises, nearly a quarter of people had what we would think was an important response. So, again, that tells us that, it's never too late for people to really work on their upper limb and see some improvements. Now, whether we can deliver that as healthcare services and quite how that happens is, of course, a separate question that we need to address. But I think we can take a very positive message that if you really are willing to work, and again, I think we should quantify that. We're talking about people doing 2 hours 3 times a week plus 30 minutes every day for a prolonged period of time. But I think our data tell us that if you're willing to invest, and if your healthcare service can give you the expertise and the required tools, you can see improvements with or without fancy devices, even many years after stroke. And I think that's quite encouraging.
Absolutely. That's super important to be able to continue to have that. And that is something that is, at least theoretically within everybody's reach today.
Absolutely. Yeah.
So in terms of then looking out to the future, and this, of course, becomes the really speculative question, When do you think VNS combined with a course of treatment from physical or an occupational therapist will actually be an option for patients, just as part of a standard treatment?
So I think it could be an option for small numbers of patients in certain countries. So particularly, for example, the US, where the healthcare environment is different. It wouldn't surprise me if these things were available, within a year, subject to FDA approval and then subject to, agreements around reimbursement. So I think we're dealing with that sort of, of timeline. Much, more wide routine availability will obviously take a little bit longer, but it wouldn't surprise me if, as I say, I obviously can't, if you like, infer what the regulatory process will be. It will look at all of the data independently and, and rightly so, and make decisions about whether it's a treatment that should be licensed for use. But assuming that is the case and happens within the normal timeframes, it wouldn't surprise me if, early next year or, in the spring of next year, it was an option for some people in quite specialized and motivated environments, though, I think.
So we're talking about a potential for commercial availability then in early to mid 2022.
Quite possibly,
as theoretically possible.
Yeah.
That's much sooner than I would have expected. So that's great. Maybe I need to start saving up for next year. So, I mean, there's lots of this fascinating stuff, and obviously stroke is just huge. That's why it makes sense to look at VNS for this. But what is it about stroke that drew your passion, that you've made this the focus of your career?
A number of things, really. I mean, I was always interested in cardiovascular medicine. Quite why I couldn't really say, and also in neurology. So it sort of just fitted. And then when I was a medical student, I did my sort of research degree and my my undergraduate degree and research project in a stroke service with some really good people that I got on extremely well with and that were really supportive, and that was it. So it was a number of things just came together, and I think it's it was obvious that it was quite a at times quite a difficult specialty to work in, obviously, and I think everybody listening to this will be listening because they have some lived experience with stroke, and they can imagine that sometimes stroke units can be challenging, emotional environments for everybody involved. But you could clearly see that it was an area where, when I was at medical school, was the start of, the thrombolysis era, and you could see that there were beginning to be changes and stroke units were forming, and it was quite an exciting, specialty that looked like it was moving forward. And then I guess you could argue there were the Baden years where there were lots of negative trials of neuroprotectant agents and not much seemed to happen. And then the past 4 or 5 years, it's become what, I sort of thought it would be, a very dynamic specialty where there are new treatments, new advances all of the time, and outcomes really are improving. So I think it was that, sort of mixture of good people, an important condition, and I think a positive future.
That's great. Yeah, it really has been. I mean, obviously, I'm just a marketing guy who knows way more about neurology and neuroplasticity than any marketing guy should ever know at this point. But just seeing what's happened over the last 10, 15, 20 years in this field has just been astounding, and how it's really come to life.
Yeah, absolutely. Absolutely.
So what are some of the biggest misconceptions then about stroke that you still encounter?
I mean, for me, I think the biggest thing is that a lot of people, when you ask them, what's the worst thing that could happen to you, the answer people always give is, a stroke. I'd never want to have a stroke, and I think there's still a belief that, stroke is it, you have a stroke and you will never have, a meaningful quality of life again. And that can be the case, of course, for very severely affected people. But I think we're all learning now that actually with the right treatment, in the right hospitals and the right rehabilitation and the right preventative treatment, many, many people with stroke can go on and live, very, very full lives. And I think that's, a hugely important message for the general public, not for the stroke survivors, because obviously they know that, but for the general public and employers and all these people, I think it's a really important message.
Well, and I think what we're seeing a lot with the growth of social media over the last 10, 15 years is that it's really given a lot of us a voice that we might not have had before. To be able to share our stories and share what we're able to do. And at the same time, I think from my personal experience too, when you just start thinking about where you are in life, I think, on June 2nd of 2017, if somebody had told me that tomorrow morning you will wake up and you will not be able to use your left hand again forever, or at least for years, that would have been a sort of horrifying thought. But, once you go through it, you kind of like, well, that's annoying, but this is still life. And this is still a pretty awesome life.
Yeah, indeed. Absolutely. Yeah, indeed. Indeed.
So aside from VNS, I mean, you're, sort of at the forefront of this amazing research and all this stuff that's going on. And there's lots of really interesting stuff that's been happening. Some of it has turned out to not be so effective for stroke, like hyperbarics and some of these other high profile treatments. And obviously stem cell research is still getting a lot of attention. And does it work for chronic? Does it work for acute? What are we doing there? What are some of the other treatments and approaches in the field that you find most exciting at this point?
Yeah, so I mean, I think it's sort of the obvious answer, but I think it still remains the true one. It has to be, for me, the advances in reperfusion therapy for large ischemic strokes and finding ways of rolling out thrombectomy and mechanical clot retrieval for the largest number of eligible people, supported by the amazing advances in imaging and our ability to identify who the right people are in almost an automated fashion with automated scan reporting is hugely exciting. AI approaches to support decision making and get these people who would have had a really small chance of an excellent outcome and almost full recovery up to in some studies almost 50% odds of an excellent outcome and full recovery is incredible. And I think we know that that's achievable. It's now just the logistics and the politics of getting it done.
There's amazing things that are happening there now, and that becomes just even that much more important for recognizing know your BFAST symptoms, balance, eyes, face, arm, speech, time to call an ambulance, because time is so critical for those therapies. And now here we are in 2021, mid-2021 especially, as we are hopefully now on the tail end of the COVID-19 pandemic. Still way too many people being infected and dying and all of that. But, even as the research has shown that even once you survive COVID, you're now at much higher risk for an ischemic stroke, large vessel occlusion. Being able to have even more access to thrombectomy or and other treatments to remove a clot becomes just that much more essential.
Yeah, absolutely. No, indeed.
And that brings us to our hack of the week after a word from our sponsor. Repetition. That's the key word for stroke recovery. The Modus Nova solutions are designed to help you get the repetitions you need to re-engage a stroke-affected limb. The Modus Hand and Modus Foot are robotic, AI-based, air-powered exoskeletons you wear while doing therapeutic exercises. Those exercises, of course, are based on video games you play on the included touchscreen display. The Modus devices help you move your hand or foot as you play. They can also resist movement to really help you get a workout in. The key, though, is that the Modus hand and Modus foot help you get in the thousands of repetitions you need to build alternative pathways in the brain to get those limbs back. To learn more and see if Modus Nova is right for you, visit strokecast.com/Modus Nova. Use promo code STROKECAST to get 10% off your first month. And now back to our hack of the week.
There is always a room and chance for improvement. So I think, my tip for, mental well-being would just be to always pick, a small achievable goal and go for it, because there isn't really any limit, for how people can improve and what they can do after stroke. There's just problems and solutions.
I love that approach. It's just problems and solutions. You got a problem, you got to figure out how to solve it. Love that.
Absolutely.
So, Jesse, this has been great. If folks want to know more about you and what you're up to, where should they go?
I guess probably just the University of Glasgow website has a page for everybody and is very easy to find on Google.
Fantastic. And we'll also be linking to that over in the show notes over at strokecast.com. Jesse, thanks so much for joining me this morning and this afternoon. This has been fantastic.
No, thank you. Good to talk to you.
Let's talk about Like-Minded for a moment. Like-Minded is the membership program created by Jane Connolly, also known as Heal the Brain with Jane. Jane is an occupational therapist and podcaster who was already active in the digital stroke survivor community before she started the Like-Minded nonprofit organization. When you join Like-Minded, you get access to live online classes by stroke survivors and medical professionals. You can learn more about the therapies you can engage in, the mindset around stroke recovery, and generally how to deal with life after stroke. You also get a private text messaging group to get answers to even more of your questions. So get the support, accountability, and direction you crave and deserve for just $45 a month. Use promo code STROKECAST for 20% off your first month. And now some final thoughts. I really enjoyed talking with Dr. Dawson. There are a few highlights that I really want to call out about his research. First of all, many folks in the study gained more function, whether they were in the control group or the experimental group. So why is that important? Because it again demonstrates that years after stroke, with intense therapy and exercise, folks can get better. The 6-month or 12-month ceilings on recovery are nonsense. And even if we don't use advanced technology, chronic stroke survivors can still get better. It's not easy. It takes a lot of work, but it can be done. Second, this experimental technology, stimulating the vagus nerve for stroke recovery, does appear to work. Folks who got the stimulation achieved greater recovery than folks who did not. And that is also a big deal. This is a promising treatment. That said, the study was still not huge. There were 107 participants split between the two groups, experimental and control. It was male-dominated and 80% Caucasian. Of course, it should be noted when we talk about race here, that the study was done at facilities in the US and in the UK. And while the US is 60% white, the UK is roughly 87% white. And as Dr. Dawson said in our conversation, they are now crunching the data to see if they can learn more by breaking the study pool down further. The results are promising, and there's an opportunity for more research and larger studies to derive even more detailed results. The other thing that I find really fascinating here is that the vagus nerve in this case isn't being used directly as part of the recovery process. When the device sends its signal to the nerve, basically, it's just telling the brain to pay attention because we're about to do a therapeutic movement. The stimulation basically primes the brain to begin learning. It opens up the question of what other ways can we stimulate the brain to just make it more receptive to therapy and to engage in deeper neuroplastic change? So kudos to Dr. Jesse Dawson and his team. It's great to know that folks are doing cutting-edge research on chronic stroke. And if this therapy is available commercially in the summer of 2022, well, that's even better. So check out the show notes over at strokecast.com/VNS for vagus nerve stimulation. strokecast.com/VNS. And you'll find links to the study and more details. Be sure to share this episode with someone you know with the link strokecast.com/VNS. Subscribe to the free monthly Strokecast email newsletter at strokecast.com/news. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.